Hi, and welcome back to the NCS podcast, current series. This is Lauren Koffman. I'm a neurointensivist at Temple University in Philadelphia. And today I'd like to welcome on the podcast author of the recent Currents article, Nurse Staffing, a Public Health Crisis in the Making. So welcome. Thanks for joining us, Dr. Jordan Yakoby.
Thank you for having me. It's excellent to be here and have this conversation.
Great. So just as a bit of a background, Jordan is the Director and Chief Nurse Administrator and Associate Professor of Nursing at the New York School of Career and Applied Studies at Torrey University. So I think before we get into, the main meat of the discussion, why don't we just tell our listeners a little bit about like the historical context as to why this is such an issue and maybe some data to support like why we should start thinking about standardized staffing.
Absolutely. I think that, really the pandemic has highlighted so many different issues in healthcare more than ever before. And it's not like these issues, including related to nurse staffing, had never been documented before, but we're really seeing the phenomenon of after the pandemic, so many registered nurses either left the profession, they left the hospital environment, and we are truly seeing the effects of a hyperacute on acute uh, issue. In medicine, we speak about acute on chronic, acute on subacute. Well, this is a hyperacute on acute problem. And we're dealing with these issues through recruiting temporary staff, including traveling nurses, and dealing with all the ramifications that come with these difficulties in not only recruiting but retaining highly qualified registered nurses. A byproduct of that is also we are more heavily relying on new graduate nurses as well in high intensity settings that may not always have the guidance from those senior nurses that have now either left the profession or left the acute care environment. And so we've known that this is an issue in nurse staffing for a very long time. And so we're really seeing that even in many cases, there's compromised patient care related to those problems.
Now, I think in your article, you mentioned that California was one of the first states to kind of enact some kind of standard. Can you just tell us a little bit about that?
Absolutely. So California is really been leading the way in terms of legislating and regulating nurse staffing, understanding that the relationship is a very strong one between nurse staffing and quality of care. In fact, there's something what we call nurse sensitive quality metrics. So many events, sentinel events, or other healthcare complications that are sensitive to the involvement and level of staffing and nursing. And so California has that throughout its entirety. There is a mandatory staffing ratio for all areas of the acute care environment, whether it be intensive care, labor and delivery, medical surgical floors, and that is enshrined in law as what with associated penalties for healthcare systems that do not follow that staffing guidance.
And so, how long has this been going on? And I guess why do you think other states haven't followed suit?
Well, it's really quite simple. There are many reasons that other states have not followed suit because this does increase significantly the amount of costs that healthcare systems, including hospitals and other healthcare players, if you will, would have to expend on nurse staffing. Currently in New York State, there was recently an article written about the within the last year or so that indicated that we're really not following the recommended staffing guidelines of for patients that the average nurse can carry anywhere from 6 to 8 patients per nurse on a regular medical floor instead of approximately 1 to 4 or 5. So if you go from one registered nurse per 8 patients to one registered nurse per 5 patients, you can imagine that's going to significantly increase the number of nurses that you are going to need to staff your organization and therefore skyrocket the cost. So, as with many things in healthcare, everything comes back to the bottom line. And so many professional organizations representing hospitals and their interests and the hospital themselves really push back against any notion of mandatory staffing guidelines for fear that they will not be able to meet those standards and not only have to increase the amount of salary support for nurses, but also potential fines that they would need to be responsible for being out of compliance with any regulation or legislation.
So now you just mentioned an article that came out of New York, but I think your article also discusses New York having its own newer legislation. Is that correct? Like that actually set forth some new guidelines?
Yes. However, I truly believe that the legislation and the subsequent regulation here in New York did not go far enough. The framework that we have in place in New York really only deals with the intensive care unit. Of course, there is a nod to non-critical care units, but again, I believe it's deficient. Currently, that framework states that we must have a ratio in a critical care area for one nurse for every two patients. Importantly, it's not based on just location, it's based on patient status. So, that could mean, if the patient is boarding in an ER but is admitted to critical care, then that patient needs to have a nurse with not more than two patients. Fine. I think that is excellent. But what is otherwise provided for is an internal hospital committee comprised of 50% nurses and 50% administrators that is supposed to come to some kind of consensus about what staffing looks like in the rest of the hospital. And I believe that's deficient for many reasons. There are obvious power dynamics between the two groups. You're sitting across the table from quite literally the individual signing your check. So there could be political pressure to agree to any proposals from administration. And there really isn't any regulatory mechanism stating what that staffing should be, what the consequences are for not having a consensus between the group, or what are the consequences for not establishing a ratio. And it just leaves too much power in the hands of the hospital.
Got it. But you just answered a few of my next questions. I was going to ask, well, what are the repercussions if people don't kind of follow through? But it sounds like that's kind of to be determined. So I guess once these guidelines or recommendations are set forth, how long do you think it does it take for it to become actual practice?
Well, these regulations are already in effect, and there is some documentation of a system already being cited by the New York State Department of Health for being out of compliance with that regulation. It's not clear to the public what the consequence of that lack of compliance would be. So I know that there's significant interest and also enforcement related to the intensive care unit in terms of being out of compliance with those ratios. And I'll just also say I hear from recent graduates of mine. I just had a phone conversation last night about a recent graduate of mine that is switching employers because of being consistently staffed with three patients rather than two. So it is an ongoing issue, despite the regulations to the contrary.
And I guess, you touched upon this a little bit earlier about like the hyperacute on acute nursing staffing shortage. So let's just talk a little bit about that. Before COVID, what do you think were the issues that were, leading to some of these staffing issues?
I think before and after, I think we're really dealing with the same phenomenon, and it's multi-pronged, if you will. It starts, first of all, there's a lack of adequate nurse faculty, so that does serve as a rate limiting step of how many students you can accept into your program, and then that in turn impacts how many graduates we're moving forward into the workplace. So that's one issue. The second issue also is that we're really dealing with a recruitment and a retention issue. It is very difficult to transition to practice from student to professional registered nurse. And we know that that transition in the intensive care unit is quite difficult for our new graduates, for them to get acclimated, for them to be properly oriented to the intensive care unit and what critical care nursing means. And because of that pressure that hospitals have with staffing issues, it tends to encourage them to release nurses off of orientation before they're ready. And so then what happens is this new graduate nurse does not feel adequately prepared to practice. And that's most likely the case. They may be placed in situations that are unsafe. And so the natural defense mechanism is for these nurses to go elsewhere where they feel more supported. And so again, that opens up yet another staffing hole, if you will, because of that. So it's really a if you want to think about it, a vicious loop, a vicious cycle that, lack of staffing begets short-sighted decisions, which then further begets worsening staffing.
And to just, I guess, to put into perspective for our listeners, in your experience and opinion, how long do you think it takes from a nurse to graduate from like nursing school to through their experiences in practice and as a critical care ICU nurse to actually be, fully competent and comfortable working in that environment?
I think that is actually a quite complicated question. There's been a lot of things done in terms of research, nursing education research, looking at just this thing. Unfortunately, the consensus is not quite there. But what I will say is that many institutions are increasingly developing nurse residency programs. So these are transitional programs that take this new graduate nurse and turn you into a competent novice and safe registered nurse in the ICU. I would recommend not less than 6 months to do that. But certainly, we know that that first year in nursing practice is critical, and that really brings you up to that phase it's kind of where you need to be to feel comfortable in that setting. And what we're seeing is that many places are only providing 4 to 6 weeks of orientation before releasing nurses off orientation, and there may or may not be consideration as to the acuity that you would assign to this new nurse. So I would say at least 6 months, but even after those 6 months, then those in charge, for example, the charge nurse, really need to think about the acuity of patients that they would assign to this new nurse until they really develop a lot more competency and comfort in the role of practicing registered nurse.
Great. And I know this is, a pretty complicated and challenging question, but, we talked a little bit about the staffing issues and perhaps not having enough time to transition into their roles as a critical care nurse. But like, are there any other things that you think are contributing to nurse burnout?
Again, it really comes down to that workload and that lack of support. So, when you have someone that is adequately supported and adequately educated, then you would have less burnout. And so I really think that it's critical that along with the staffing issue, it's not just about getting in the bodies to fill these gaps, but you then also have to adequately prepare these individuals. Much like medical school, nursing school prepares the generalist, someone who is what we call minimally competent to safely practice. So you have to invest in that individual and teach them what are the ins and outs of critical care nursing, clinical pearls to help them really develop their clinical judgment as it relates to critical care. And so there's so much that needs to be done in the education and the continued professional development of these nurses, so that not only are they there filling in a gap in your matrix, but then they're also not actually competent to understand what are they looking for in while they're caring for these patients. What should they be doing next, and adequately exercising that clinical judgment, cognitive muscle, if you will.
So, I guess what can we do as physicians to help support our nursing colleagues?
Absolutely. So I think one of the things that we can do from the physician perspective or the advanced practice provider perspective is when we're discussing our cases, our patients with our nursing colleagues, we should ask them what are their concerns, but we should also ask them and, give a little bit of mentorship ourselves. Do you have questions about the plan of care? Here's why we are doing what we are doing in this patient's plan of care. And here are the things that we're hoping that you'll help us look out for. If you see this happen, if you get this lab result, or if the patient reports this, these are all things to be concerned about. And through this kind of informal mentorship or expectation setting, or giving them information about what you're looking for or what you're concerned about, it really trains that new nurse to say, hey, this is what they're concerned about. That's why they're concerned about for it. Let me look for that. And then it can lead to a conversation in which that nurse asks questions. Well, tell me more about that. Why is that a concern? Or my patient has developed this symptom, or this event happened. Should I be concerned about it? Why? And really, that dialogue can help them also develop professionally in that way as well. And I've used it and I found it to be very helpful. And, even during rounds, you can say, what are the things that you think we should be looking out for? And through that conversation, really build their knowledge base too.
Great, thank you. So I guess going a step beyond, a layer above the individual physician, or I guess team of providers, what can hospital, like as systems as a whole, or organizations do to advocate so that we can improve the way our nursing colleagues are being treated and, want to retain them within our practice?
This is really a paradigm shift. We have to look beyond the fact that, yes, initially increasing nurse staffing is going to cost more money, but really, does it cost more money? I would argue it does not, because while you may be spending more money on FTEs, what you'll find is those nurse sensitive indicators, that those quality of care metrics that are really sensitive to nursing care, you'll find that you have shorter length of stays, decreased complications, including nosocomial infections, pressure injuries, and falls. And you'll actually end up saving money by investing in more human capital, if you will. So in the long run, it will result in a cost savings. And I think that's that shift in philosophical thinking that we need our hospital administration colleagues to really be cognizant of, so that we can really benefit and reap the rewards of this long term. There was a study that actually showed that California, with their staffing ratios, have a statistically significant decreased length of stay and decreased patient mortality compared to other places in the country when controlled for a variety of factors.
Yeah, so certainly it's not a short-term solution, more of a significantly long-term fix. Any other final words you want to share with our listeners?
I would just have to say that really addressing this issue of nurse staffing really is not just about the critical care unit, and it really will benefit so many different areas of the hospital. And so addressing this will even help us to shift our focus less from the acute care environment and more on prevention and health maintenance. By increasing nurse staffing, this is more time that nurses have to spend with patients, to do patient teaching, to make sure that they understand what their medications are, why their medications are important, to ask them, can they afford and obtain their medications, and address any questions before they leave the hospital to really prevent them from coming back to the hospital a second time and avoiding those readmissions.
Well, thank you so much. We really appreciate it. I'll make sure that there's a link to the article in the show notes to check out this or other Currents content. Please head to currents.neurocriticalcare.org. As a reminder, NCS offers free CME for select podcasts. Listen by the NCS Learning Center and complete a short survey to receive your credits. Otherwise, you can access the NCS podcast wherever you get your pods. Don't forget to add us to your favorites.